Yes, I think so. Yes.
Okay, so good morning, good afternoon, and good evening to all the respected teachers, the chairperson, the presenters, the speakers, and the panelists, and all the friends from all across the world. I welcome you on behalf of ACNS YNS for this yet another interesting ACNS YNS webinars, which we conduct on every second and fourth Sunday at 7 p.m. Japan's time for sole purpose of education of young neurosurgeons, especially from the low resource countries. And for today's session, we have three interesting speakers. The first speaker is Professor Shiro Horisawa. He is the professor, Department of Neurosurgery at Tokyo Women's Medical Hospital, and he's an expert in functional neurosurgery. I had an opportunity to be with him for some time. The second speaker will be Professor Dilshad Mammadaliyev from Uzbekistan, a young neurosurgeon, and another young neurosurgeon speaker from China, Dr. Liu Mao. To chair today's particular session, we have Professor Abhida Shah, who is the professor at St. G.S. Medical College and KM Hospital, Mumbai, India. And the discussion for today's session is Professor Wozniak Alexander, who is the president of Ukrainian Society of Neurological Surgery, and Professor Fawad Tevzad will be joining us shortly, who is the president of Afghanistan Society of Neurological Surgery. And as usual, our patron, Professor Yoko Kato, who is the president of ACNS.
Oh, thank you very much. So, I'm so happy to can you hear. I'm so
yes.
Can hear. Okay. So thank you very much, Sachi. So I'm very happy to receive the very good speaker. Horisawa Sensei is an expert of the functional neurosurgery, maybe top 5 in Japan, I think. And also Dilshad, everybody knows that he is from Uzbekistan. Now, currently he is in Nagoya, as a fellowship, Nagoya University. He's doing ABEC surgery at Nagoya University right now. And also we are so happy to have discussants, the Bosniak from Uzbekistan, no, sorry, the Ukraine, and also the Fawaz. So hopefully I think Bosniak, that you are fine, you are safe. Okay.
Yes, everything's fine.
Okay, good.
Yes, okay.
Excellent.
Everything.
Okay.
At least we are safe. Yes.
Okay, thanks. So that's why the chair is Abhida Shah. He is an expert of the MC, I think. Okay, so please start.
So
thank
before
you, Professor.
We start, yes.
Yeah,
Yes,
go ahead,
No, I was requesting you only to
okay.
Please allow us to open the webinar and say a few words before opening.
Okay. So thank you, Sachin. Thank you, Professor Kato, for this invitation, and looking forward to yet another exciting webinar with the ACNS YNS. And I think we should start. So we can invite our first speaker, Professor Shiro Horisawa, and I would like to hear your talk on this functional neurosurgery. Thank you.
Okay, thank you, Chairman. Can you see my slides?
Yes, we can see.
Yes.
Okay, so today I would like to talk about a lesioning surgery for unusual movement disorders. And the majority of the young neurosurgeons consider the functional neurosurgery means deep brain stimulation for Parkinson's disease, but that's not true. So actually, we can treat more and more diseases by radio frequency regioning, which is a very old-fashioned but very simple and safe procedure, which is also available in the majority of the Asian countries. So the first indication is a progressive supranuclear palsy, which is a neurodegenerative disorders. And as a neurosurgeon, this disease is very rare diseases, and actually the prevalence rate is 5 per 100,000. And the two types of the PSP exist. One is the Richardson syndrome, which is a very fast progression and very miserable course. And another type is a Parkinsonism PSP, which is a slowly progressive and respond to L-DOPA. But both types present an inability to control eye, and the problem is balance and mobility, or speech and swallowing problems. And these patients usually have frequent falls and the slowness of thought and memory problems. And we cannot treat these kind of diseases in PSP, but 20 to 42% of the PSP patients have a tremor, and 13 to 30% of the PSP patients have dystonia. And these tremor and dystonia PSP patients we can treat. And several years ago, University of Toronto tried to confirm a randomized clinical trial of a deep brain stimulation on the penetrant nucleus stimulation in PSP patients, 8 patients with Richardson syndrome. They tried to improve gait and postural instability and falls, but unfortunately, these clinical trials showed no significant improvement of these movement disorders and gait and postural stability in 8 patients. But this is our patient, 71-year-old woman. She was a PSP Parkinson type, and she had a gait disturbances and frequent falls, and the rigidity and the resting tremor in the left hand, and the dystonic posture in the left foot like this. And this is a pre-operative condition. Left hand shaking, but right hand looks completely normal. But she had rigidity in the left hand. And this is a dystonic posture. And her balance problems. And the dystonic left foot hampered her walking condition. And she received the right side VI ventral intermediate nucleus, which is usually useful for essential trauma surgery. The same target, thalamotomy, thalamic region in the right side for the left side symptoms. So this is a few days after the surgery. The left hand movement and left foot dystonic posture improved. Due to the improvement of the left dystonic posture, her walking balance problems mildly improved. And this is 3 months after the surgery, the patient listing a tremor of the left hand completely improved. So this is a very good indication of radiofrequency lesioning. And the next is a Huntington disease. This is an inherited disease, and the prevalence rate is 20.3 per 100,000. This is also very rare movement disorders. And the Huntington disease includes cognitive and psychiatric disorders and the movement disorders. And the movement disorders include the chorea and the gait and the posture and the balance problems and the speech and the swallowing difficulties. And this is a paper reported by Professor Marwan Halitz and in Brain 2017. And he said what is less well known is that the first ever stereotactic operation was performed 70 years ago and was for treatment of Huntington disease. And among all movement disorders treated by stereotactic surgery, Parkinson's disease, essential tremor, multiple sclerosis tremor, dystonia, one condition is barely considered for surgery. It is Huntington disease. The very first application of functional stereotactic neurosurgery some 70 years ago. So nonetheless, the movement disorders community would do well to lead all the publication of the pioneers of stereotactic neurosurgery, in order not to forget that stereotactic surgery may be of some benefit for patients with Huntington disease who are not severely cognitively impaired and who suffer from medication refractory chorea. And surprisingly, only 4 patients have been treated by the stereotactic neurosurgery in Huntington disease patients. This is the only available paper investigating the reasoning surgery or deep stereotactic neurosurgery for Huntington disease. And the Spiegel and Weiss, 1949, both are father of a functional neurosurgery, and they reported the thyrotomy may diminish the improvement involuntary movements, but paridotomy, internal segment of the Gerber's pallidus regioning seems to be more promising. The involuntary movements in Huntington's chorea could be nearly completely abolished by lesioning. And this is our case. The young onset, a very severe Huntington disease. She presented the very severe correct movement in bilateral upper and lower extremities and the neck and the trunk. So due to the very severe correct movements, so she could not stay calm in the sitting position or in bed position like this. And she received, and her brain MRI showed the atrophy of a pallidum. So the majority of the Huntington disease patients present the atrophy of the basal ganglia. And if you choose the pallidotomy in these patients, this atrophied pallidum and the medial to the pallidum, this area is an internal capsule, a posterior rim of the internal capsule. So the lesion encroachment on this area can lead to a severe hemiparesis. So that's why we considered the pallidotomy region here may be the risky for these patients. And we selected the pallidothalamic tractotomy lesion at here. This field receives the output projection from the GPI pallidum. So the effects on the movement disorders at this region completely same as those of the pallidotomy. So we prefer this target over the GPI in terms of regioning safety. So this is a post-operative MRI. This area is a pallidothalamic tract regioning away from the internal capsula. And this is 1 day after the surgery. And surprisingly, that patient receives the bilateral benefits after unilateral regioning surgery. And this is 6 months after the lesion. And she had been completely wheelchair bound for 2 years before the surgery. And she became to walk independently without severe correct movements. So the Huntington disease is a very good indication of the lesioning surgery. So the neuroacanthocytosis, this is also a very rare movement disorders. This is an autosomal recessive or X-linked recessive diseases, and the prevalence rate is 1 per 1 million. And neuroacanthocytosis shows a misshapen red blood cell, which is also called acanthocytes. And this disease presents a progressive neurological decline and movement disorders, such as chorea, dyskinesia, and dystonia dysphagia. And in this disease, so many papers use the deep brain stimulation on the GPI, and the dystonia and the chorea are greatly improved by the DPA-DBS. But we can treat this kind of the patients by lesioning surgery. So this is a neuroacanthocytosis. So she had a bilateral correct movements. And the left side parietal tract regioning. On the right side of the correct movements completely improved after left side surgery. But left-sided symptoms stay the same, not improved. Right hand was normal, but left hand not. And see good right, very fine Japanese characters by the right hand. And 1 year after the surgery, she received the contralateral side paradotomy. This is a left hand correct movements before the surgery. And while the stimulation, the patient's correct movements instantly improved after the stimulation. And when we stop the stimulation, the patient's correct movements reoccurred like this. And we started to make a lesion. So immediately after the lesion, the correct movement of the left hand improved. So this is the 1 day after the regioning of the right side.
もう一回両手万歳して。あ、手落ちないね。グッパグッパできる。大きなパー。大きなの。お、できる。うん。そしたら両手両足使えるようになったね。嬉しい。嬉しい。ありがとう。20時間どうですか？先の乗りますか？
So the neuroacanthocyte is a very good indication. And follicular dystonia, this is a very, very rare reported indication, which is also called a moving ear syndrome. At this moment, less than 10 patients reported in this movement disorders, and all of the movement disorders in ear dystonia are treated by botulinum toxin injections or medications, not treated by DPI-DBS or regioning. And follicle has several very, very tiny muscles like this, and it can the dystonia can happen in the follicular muscles. This is our patients. So you can see the strange movements of the ear. This is the right side. Several auricular muscles are involved in the dystonic movement, and this is the left side. This is the dystonia. You can see the mild movements in this the left side auricle, but right side was prominent, so we decided to left side pariethalamic tracheotomy. And the area, very small region here, and this is 1 week after the lesioning. So the movements of the auricle, you cannot see any movements of the right side auricle. And this patient also received left-sided improvement of the left side dystonia. So the one side unilateral regioning surgery provided the bilateral benefits. So the next indication, the dystonic camptocolmia, also called a bent spine syndrome, like this. This is our patient.
ちょ
So
っと足踏みしてみてください。だんだん前かがみになってくる感じ。で、お腹に力が入る。
and we need to carefully differentiate the camptocolmia come from which diseases, the Parkinson disease or dystonia. And Parkinson disease or dystonic patient can present the camptocolmia like this. And this is a very important thing to know, the Parkinson disease camptocolmia or dystonic camptocolmia, because this article showed the good response of the deep brain stimulation in dystonic camptocolmia, but not in Parkinson disease camptocolmia. So this is a very important point. So the dystonic camptocolmia is a very good indication of the stereotactic neurosurgery. This is our case, dystonic camptocolmia treated by the regioning surgery. So this is the before the regioning. So trunk bending present while walking, but not while running. So these strange things usually can be confirmed in dystonic patients. This is a task-specific camptocolmia dystonia. This is the condition after the left paralotomy. And 1 year after the right, this is a few weeks after the right side paralotomy. So the patient's dystonic camptocolmia completely improved. So this is a very good indication of the paralotomy. So the paroxysmal kinesiogenic dyskinesia, the PKD, is this is an autosomal dominant disorder and a very rare diseases. And these movement disorders present the transient dyskinetic movement triggered by sudden voluntary movement. And 50%, half of the patients experience the spontaneous remission with age. And the majority of the patients can receive the complete remission by the carbamazepine. But some of the patients experience the sleepiness with the carbamazepine with treatment dose, and half of the patients does not experience the spontaneous remission. This is our patient. So left hand dyskinetic movement triggered by suddenly voluntary movement. And this young boy had dyskinetic hand and foot movement in the left side. And his father had a paroxysmal kinesiogenic dyskinesia. His grandfather had PKD, and he was treated by Professor Kenichiro Sugita by stereotactic lesioning surgery. And we asked his grandfather to come to our hospital to confirm the lesion location by MRI. And this is a sagittal image of his grandfather. And this is an anterior commissure, this is a posterior commissure. The region here, this location is the ventrolar nucleus of the thalamus, which we frequently use for focal hand dystonia treatment. So based on the MRI findings of his grandfather, we selected the ventrolar thalamotomy for this young boy for the left hand and the foot dyskinetic movements. And 1 year after, just immediately after the surgery, the dyskinetic movement completely improved. And 1 year after, the patients suffered from a contralateral side dyskinetic movement. And he received a contralateral side ventricular thermotomy. This area represents the VIM, ventral intermediate nucleus, which is a good target of the essential tremor surgery. And the ventricular nucleus just entered to the VIM nucleus, so around here. So we make a lesion on the VO nucleus of this patient. And fortunately, the patient while the 7 years follow-up, the patient had never paroxysmal kinetic dyskinesia movement for 7 years. So the ventricular thermotomy is a very good indication of the PKD symptoms. And another, the baseball dystonia. This is a task-specific dystonia. And in the professional athletes, the sports-related dystonia can happen in some professional athletes. So in the baseball, the very famous baseball players suffer from task-specific dystonia. So he cannot slow to the first ball correctly. This is John Lester in Boston Red Sox and Chuck Knobloch in New York Yankees. But this sport-related dystonia never treated by the surgery outside of Japan. And this is our first case of the baseball dystonia. He is a college baseball player. So his command is very bad. And he received left side ventricular thermotomy. This is the 1 day after the surgery.
ちょっと一回俺取るから普通に投げて普通に投げていいよほらもうど真ん中来たよいしょ
This is 1 year after the surgery.
Oh, いいね
So
いいよまたそ
now he completely come back to the baseball team, and he played the baseball very well without any deficits or dystonia. So this is a pre-operative condition. So please look at his elbow and wrist angle. This is a very bad manner of the slowing a baseball, and the lower presents the correct position of the slowing a baseball the 1 year after the surgery, and he could slow baseball very correctly. On the right side, MRI shows the lesion on the ventricular nucleus. And lastly, the Moyamoya disease. Movement disorders in Moyamoya disease, and 6% of the Moyamoya disease patients develop movement disorders in Korea, dystonia, hemiparesis, and limb shaking. And the ischemic dysfunction and imbalance in the basal ganglia cortical circuit may be the cause of these movement disorders. And approximately 30% do not respond well to the revascularization surgery. So the 70% of the Moyamoya disease patients and movement disorders improved after revascularization surgery. And this is the first report of dystonia in Moyamoya disease patients treated by the stereotactic neurosurgery reported by China, Shanghai University. And the patient received the ventricular region and the GPI deep brain stimulation. And this is our case. Moyamoya disease presents limb shaking, and a few years after the bilateral STMCA biopsies. So you cannot see any abnormal findings on the T2 MRI. And we carefully checked the abnormal vessels of the basal ganglia and the thalamus by the angiography. And we this is a preoperative limb shaking in the left foot and the left hand. And we did a right side ventral intermediate VIM thalamotomy. So immediately after the lesion, the limb shaking completely improved, like essential tremor surgery. So Moyamoya disease is a very good indication of the lesioning surgery. So this is a postoperative MRI. So tiny lesion on the right side ventral intermediate nucleus. Sorry, this is germinoma related movement disorder. This is also a very good indication of the lesioning. This patient had a pineal region tumor and removal surgery. And a few years after the removal surgery, the abnormal dyskinetic movements developed in the face and trunk and the bilateral upper limbs. And this is a post-operative, preoperative conditions. So left arm and neck movements were really disabling for his daily lives. So this is a few days after the lesioning, right side. So there have been no reports of germinoma-related movement disorders, but we frequently encountered the dystonic movements after the pineal surgery in the germinoma patients. So these kind of dyskinetic movement is also a very good indication of a lesioning that he received the right side pylorothalamic tract lesioning. So the last slide, I would like to emphasize unusual does not mean the difficult to treat. And today, all of the patients I presented in this slide received the lesioning surgery, not DBS. So I think that most of the cases do not require the deep brain stimulation. And the usual movement disorders, such as the dystonia and the tremor, in unusual disease is a good indication of the lesioning. And unusual dyskinesia and the dystonia is also a very good indication. And chorea should be considered as a surgical indication. So thank you for your attention. Okay.
Thank you,
Yes.
Professor Horisawa. That was
Yes.
a fascinating presentation to see such unique disorders being treated, in a unique way. So it is quite amazing to see this. I don't do functional neurosurgery myself, but these results are quite good. I wanted to ask you, how do you decide the site of the lesion? On what is the anatomical and physiological basis of?
Yeah. That's a very good questions. And Usually, all of the neurosurgeons consider the GPI-DBS is for dystonia, for example, but we use GPI, internal segment of the paradigm, good indication for proximal symptoms, the face, neck, and the trunk, and the pariethalamic tract is also good for proximal symptoms. But distal limb symptoms, foot and hand symptoms, and we use the ventrolar nucleus of the thalamus. That is a best target for distal limb symptoms.
Thank you, Professor. Yeah. Yes, Professor Kato, would you like to make some comments?
Yeah, you're muted.
Hi, Horisa Sensei, thank you very much. So how you can decide the size, the lesion?
Size of the lesion.
Yes, size, yes.
Yeah. That's also a very good point. And we use a 1/4 insulated tip of the electrode and 70 degrees 40 seconds, which makes 50 to 60 cubic millimeters volume of the lesion. And that is a very safe volume. But if we make 100 or 150 or 200 cubic millimeters lesioning in GPI or VO, which I think that is too much lesioning. And in case of that, a big lesion, the patients sometimes have a very severe hypotonic deficit. So the patient became to walk very unstable or hypotonous. So that we try to make a lesion less than 100 cubic millimeters.
Okay, thanks so much. Thank you. It's very interesting presentation. Thank you so much. Excellent.
Yes.
So thank you very much. May I request the discussions for today's session, first Professor Alexander Wozniak to make some comments about your experience of functional neurosurgery and Professor Shiro Horisawa's presentation.
Yes. Professor Horisawa, thank you very much for great presentation. Really impressive, really excellent results, actually. You showed the cases which, for example, in my country are mainly treated in the neurological departments almost without success for many years, and patients disabled, too much disabled. So maybe we will start do something like this. So thanks to your presentation. Your talk proved once more that any evolution goes like a spiral shape. You remember that the stereotactic surgery started as a lesional surgery. We used liquid nitrogenum, coagulation, so on and so on. Then it was replaced almost completely in the world, replace it with the stimulation, with the stimulative surgery. But actually, both of them, the aim, both of these methods were the same: to disrupt the pathological chain, bioelectrical pathological chain. It seemed that stimulation is more safe. It's reversible, you can adjust it. But my question is, why the tendency to lesional stereotactic surgery came back, and what is the prevalence of just the destruction, not stimulation? So please, can you answer this?
Okay.
Yes.
Thank you for your comments. And nowadays, in developed countries, we can use the focused ultrasound lesioning without the skin incision. By ultrasound, focused ultrasound can make a lesion. Yeah. So that is probably one of the main reasons. Come back to the lesioning surgery. Many neurosurgeons look at the old-fashioned, but the lesioning surgery when it comes to the FUS treatment. But I think that we also use the deep brain stimulation, but in case of very severe generalized dystonia or Parkinson's disease, the majority of the patients require the bilateral lesioning surgery if you want to use the lesion. And the dystonia patient is a good indication of the bilateral lesioning surgery. The serious complications associated with the bilateral lesioning surgery include very severe hypophonia or very severe dysarthria or dysphagia, which really, really rarely happened in bilateral regional surgery in dystonia patients. But in Parkinson's disease, they are very, very fragile for a bilateral regional surgery because the disease itself have the dysphonia or dysarthria or balance disorder. So I think the Parkinson's disease, non-tremor Parkinson's disease, is a not good indication of the lesioning surgery. So for those cases, we use the deep brain stimulation. So that is Parkinson's disease is a very difficult indication of lesioning surgery. And one more, essential tremor. Essential tremor patients, majority of the patients for long-term follow-up, the tremor come back if you treat the deep brain stimulation in essential tremor. So, but in case of the lesioning surgery, the long-term results are really, really nice. So I think the essential tremor is also a very good indication of lesioning, and I do not use the deep brain stimulation as much as possible for essential tremor patients. For two indications are good for me to do a deep brain stimulation over the lesioning surgery.
Okay, thank you very much. Thank you. It's very interesting. Thank you for a very good comment for this explanation. Because as I can conclude, so nowadays we try to separate the patients with different pathologies for lesional surgery and for stimulation therapy. So we are in the process of separation of patient for all these procedures. Yes, as I understood you clearly.
Thank you. Thank you.
Okay. Thank you. Thank you very much. Thank you.
Thank you so much.
Thank you. Thank you very much, Professor Wozniak Alexander. I think Professor Fawad Pirzad is operating. Are you
Yeah. Hello.
Are
Good
you
evening.
to
Thank you.
have a comment?
Yes, konnichiwa. Sorry, I'm busy in operating theater. It's emergency case and broken spine, and as you know, we are facing with now all with traumatis as well. And this our ET and our colleagues, and this we use portable X-ray machine for fixing the spine. Sorry. And this. Thank you very much. Thanks for the presentation. But unfortunately, we are don't do the surgery for moving disorder because it's very advanced for Afghanistan. We are still facing with trauma cases as well. Thank you very much.
Thank you.
Thank you. Thank you very much, Professor Fawad Pirzad. You can see one hand raised by Dr. Hari Kiran. He's currently a fellow at Toyota Health University in Japan. Dr. Hari?
Hello. Hello.
Yes, please go ahead. Please ask a doubt.
Thank you, Professor, for an excellent presentation. I have two questions. So one is, how much time do you use for lesioning? Is it 1 minute? That is what commonly we do. Is it for 60 seconds you do lesioning?
70 degrees, 40 seconds.
40 seconds, okay.
Yeah.
And my second question is, how much time do you wait after the lesioning to see the results? Is there any specific time? Do you wait for some time to see the full
Okay,
effect?
okay, so good question. At least 6 months we have to wait the final results of the one lesion surgery, because some patients, some dystonia patients, completely improved just after the lesioning, within 2 weeks, but later on the symptoms slowly re-emerged. And for those patients, we have to move to the contralateral side lesioning surgery. So we have to carefully check the 3 to 6 months post-operative condition after the lesion.
Okay. Thank you, Professor.
Yes, thank you.
Thank you very much, Dr. Hari. So, do we have any other comment or any doubts from any of the panelists or any students? You can see
there is a question in the chat box and by Dr. Yaru. And the question is, do you have stimulation-induced dyskinesia after deep brain stimulation for Parkinson's disease? And what is the cause of it?
Sorry, say it again.
Professor, in your experience, do you have stimulation-induced dyskinesia after DBS?
For Parkinson's disease? Actually, no. I have no experience of the stimulation-induced dyskinesia or dystonia. But the lesion-induced dyskinesia very, very rarely encountered, and STN. So our lesion of the pareothalamic tract just medial to the subthalamic nucleus. So lesion encroachment of the medial subthalamic nucleus may lead to the hemiparesis. So we have 3 cases of region-induced dyskinesia and successfully treated by GPI DBS.
I see. Thank you so much.
So, thank you very much. Do we have any other question from anybody?
Professor Shiro, Sachin, one of my younger colleagues, Dr. Ravi Kiran, is very interested in functional neurosurgery. I think he's there on the webinar. Maybe he can learn from you. Ravi?
Hello, madam. Fantastic presentation, Professor Shiro.
Thank you.
Sir, I had one query in the sense, at what interval do you do the bilateral lesioning? What is the shortest interval that you probably suggest?
Yes, that's a very good question. And in dystonia patients, we set at least 6 months interval between 2 surgeries, because we have to check the post-operative results 6 months after the surgery. And we also carefully check the side effects of the regional surgery. Yes, and some patients experience the late onset side effects, such as dysphonia or balance disorder after the regional surgery, which that symptoms we cannot detect immediately after or a few weeks after the surgery. So if we our patients experience such kind of the deficits, we have to wait additional more several months to improve. And if patient does not improve, have the improvement of the side effects, we don't select the contralateral side lesioning surgery for the safety. So we have to choose the deep brain stimulation for to avoid the additional complications by the lesioning.
Okay, sir. Okay. Sir, and one more question. Does lesioning increase the indications for surgery in Parkinson's, usually we restrict ourselves to tremor and rigidity. It is predominantly DBS than lesioning. Does lesioning provide any more additional symptoms that can be controlled apart from these, for example, some axial symptoms or maybe hypophonia or imbalance, to see if we can expand the symptoms that we can actually control with lesioning over DBS?
I think the indication of lesioning surgery, the Parkinson's disease symptoms, the good indication is a tremor and the rigidity and the dyskinesia. Only 3 symptoms. So I think other than wearing off phenomenon or axial or phrasing of gait, such as gait disorders, are not good indication of the lesioning. So I think, but the deep brain stimulation in the upper midbrain area, just cross the pedunclepontine nucleus, recently reported by the Brazilian neurosurgeon. They report the axial or phrasing of a gait or balanced problems improved significantly after the bilateral deep brain stimulation at the pleural field deep brain stimulation. So I think these symptoms may be the next indication of the deep brain stimulation surgery in Parkinson's disease.
Right. Thank you, sir.
Dr.
Thank you.
Sachin?
Thank you very much, Dr. 𝑧𝒂𝒑. So we'll move on. Yeah, Oraz, do you have any comment? Please introduce yourself.
One question. Yes, one question. Thank you, Professor, for nice presentation. I have one question about the patient selection. How do you select the patients? Is about due to the severity patients or due to an effect of medical treatment, or do you use any scale for that dystonia or about that? And after surgery, did you follow it by physiotherapist or something? It's a little bit about that, if you comment.
Yes, the indication we decided at least the medically refractory is the most good indication, and that symptoms significantly impair the patient's quality of life, but we cannot understand how much difficult that symptoms impair that patient's quality of life, and the patients themselves have to decide the surgery or not. So before the surgery, I explained a lot about what will happen in good or bad aspects after the surgery, and after that, patient have to decide I want to have the surgery or I do not. So the last surgical indication should be made by the surgeon, the patient. Okay.
Thank you. Thank you very much, Dr. Oraz. So we'll move on with our next speaker. Our next speaker is Dr. Dilshad Mamad Aliyev, who is a neurosurgeon and is also Secretary of Neurosurgical Society of Uzbekistan. He's currently working at the Republican Special Scientific and Practical Center of Neurosurgery, Tashkent, Uzbekistan. And at present, he's in Nagoya for advanced training. He's going to talk about doing more with less, awake brain surgery in low and middle income countries. Dr. Dilshad, yes, we can see your screen into full screen.
Thank you so much, Sachin, and everybody. Good evening, konbanwa, dear senseis, dear mentors, dear colleagues. Happy to present between these great mentors. So, just a moment. So Am I audible enough? No.
Yes, you're audible and everything is clearly seen your slides.
Okay. So one of the English philosophers said, "It is vain to do more what can be done with less." It's a William Ockham, great English philosopher. So following this theory, the basic concept of neuro-oncology is providing a patient long-term survival and preserving the functionality of the brain cortex and subcortical regions, which is usually in our days can be through awake surgery and brain mapping is best provided. So if we see historical notes, sort of awake craniotomies was applied to management of epilepsy, even in ancient times, in diverse archaeological data from Egypt. So in papyrus and many other sources of Egypt archaeology that can be found. And the first steps was done by Robert Bartholow, who has used Faradic electrical currents to patient's cortex. By stimulating the cortex, he has localized the anatomical and functional areas of the certain cortical regions. Basically, it was a motor area. And then Sir Victor Horsley from England localized the same epileptic focus with the cortical stimulation in 18th century. And then Wilder Panfield, a brain surgeon and researcher, made a mapping in a conscious patients with analogous pathology epilepsy under local anesthesia. And everybody knows about Dr. Professor Brodmann from Germany, who has made a cytoarchitectonic map of the brain. So how we define the awake surgery is a type of surgical procedure which is performed under local anesthesia and keeping patients alert and conscious or slightly sedated for some portion or the whole surgical procedure in order to monitor eloquent brain areas. So what are the eloquent brain areas? So basically, from the history, eloquent literally meant by fluency of the speech. So it was basically indicating the Broca's area and the Wernicke's area, which was 44 and 45 Brodmann areas. And then the concept of eloquence has extended and expanded to the motor regions, sensory regions, visual cortex, auditory cortex, and many other cortical regions, but not only the cortical regions. There are, by the evolvement of the neuroimaging, there has been found many subcortical networks, fiber bundles, which are huge impact, which gives a huge impact on functionality of these eloquent areas, like inferior longitudinal fascicles, inferior frontal orbital fascicle, and superior longitudinal fascicle, and many others. So the language itself can be automatically driven by at least 6 these subcortical areas. So this is changes the dogmatic principle of having only intact cortical Broca's and Wernicke's area is not enough, and so we need the normal functioning of these subcortical fiber bundles like arcuate fasciculus, middle longitudinal fasciculus, superior longitudinal fasciculus, uncinate fasciculus, an extreme capsule. So awake craniotomy is being one of the most often employed procedure to map and resect the tumor of eloquent brain areas, avoiding use of general anesthesia, decreasing the complication and the cost of the surgery. But from the perspective of low and middle income countries, this is being challenging. Resource limitations are being one of the basic reasons to avoid this kind of surgery. The reasons to application of this method of surgery, so it facilitates to resect needed volume of the tumor, sparing eloquent cortex and subcortical regions. It's robust and versatile, decreased iatrogenic neurological injury. It improves the healthcare resource utilization. And in developing countries can facilitate access to neurosurgical care and very low resource settings. A high satisfaction rate from the patients has been reported, and effective communication establishing the doctor-patient relationships. It allows neurosurgeon to test regions of the brain before they are incised and continuously, even throughout the procedure, increases the scope of the tumor that are considered resectable and in general reduce the recovery time. So the indications are basically anatomical, physiological. The physiological indications has been already presented by previous speaker, Horisawa Sensei, about the using of stereotaxis and many movement disorders, and the space-occupying lesions which are infiltrating speech and eloquent brain zones, motor cortex, prefrontal cortex, and sensory cortex, basically. There are exclusion criteria, which are several in group. So confused, delirious, debilitated, psychologically unstable patients are not the proper candidates. There are limited age group. So the younger patients than 11 years are discouraged by some authors. And there are some reports about using the procedure, this surgical method for even 9-year-olds children, but they are not so much. However, it is individually assessed. In the tumor location, there are mostly supratentorial locations of the tumor, and the tumor types should not be very vascular, so it can cause a high blood loss during the surgery, and not a very large volume leading to huge brain edema. And comorbidities like sleep apnea and very obese patients are not the proper candidates. And of course, inexperientness of these specialists is also exclusion criteria. So the benefits of the surgery is a shorter ICU stay, fewer neurological deficits, shorter hospital stay in general, less risk of general anesthesia-related complications, post-operative pain, nausea, and vomiting are reduced in, which is also related to general anesthesia. So there are 3 basic anesthesia protocols which are used worldwide, but they are also constricted into 2 basic, like conscious sedation, the sedation, slight sedation of the patient throughout the whole procedure, and awake asleep procedure, which we have chose also in our series, sedation during until the duotomy and awakening, and the sedation after removing the lesion. So preoperatively, we have to rule out the concomitant disease. We have to be good prepared with the patient, psychologically preparation, and their relatives. It should be an utmost importance of painless, comfortable, and intraoperative conditions should be reassured. Intraoperatively, there should not be any noise. Staff movement, instrumental noises should be restricted. Calm atmosphere, ECG, and other instrumental monitoring sets are standard. Urinary catheter, local anesthesia is very important to provide a scalp block. Dural anesthesia on the side of the lesion is very important, usually made by a bupivacaine and epinephrine mixture. This picture depicts the basic steps, which is standardized in many developed countries. There is head clamp, which is many different types, Mayfield or Sujita or many different others, neuronavigation sets, and then the other steps are regular craniotomy and tumor resection procedure. So I have found this article very interesting about the perspective of awake craniotomy in the low and middle income countries, scoping review of the literature and the challenges. So recent global estimates indicate that all the more than 22.6 million of people suffer from disorders and injuries requiring the expertise of neurosurgeons yearly. About 5 million individuals are unable to undergo the required neurosurgical treatments because of multiple factors, including resource limitation. And including the awake procedures are also in this problem, also included. In low and middle income countries, resource limitation, intensive undertaking usually requiring postoperative hospitalization and rehabilitation. So in this map of Africa, you can see that the most spread colors is red, yellow, and orange, which indicates the lack of accessible training in awake craniotomy, lack of information and support for patients, which is generally means the patients are not informed about the existence of this kind of procedure at all. And the patient have delayed the diagnosis, which is also can be traced to the inexperience of the neurosurgeons or a diagnostic workup, or the late referral to the centers. So these are the basic challenges, and I can say not only in the African countries, but also in the Central Asian regions, possibly. So the basic challenges: lack of access of intraoperative neuro monitoring and other infrastructure, lack of access to specialized skills for using neuromonitoring, inappropriate health-seeking behavior. Some patients just go to the like neurologist or any other specialist who are not aware of what to do with the tumors of the eloquent areas, especially regarding neurosurgical care. Inadequate healthcare infrastructure, lack of trained neurosurgeons, anesthesiologists, psychiatrists, misconception of the technique by patients, and poor acceptance of neurosurgical procedures, lack of anesthetic medications such as propofol, fentanyl. For example, we don't have remifentanil, dexmedetomidine, lack of awareness of the availability of this procedure. So this is the basic schematic room setup in operation room. So we should have a operating team, neurosurgeons. We have a nurse, we have a anesthesiologist and its equipments and navigation system, epileptologist, an OR technician, microscope, obviously the last one, and the electrostimulator, in this example, Algerman stimulator, any other, a neurophysiologist. So there are about 10 operation staff is working. It's a huge team, but this is the ideal situation for performing the awake procedures in the developed countries. So this challenge can be adapted to the low and middle income countries. Setting up operation room at the minimum basis. So the positioning and draping is just as standardized. So we use also the single drape to cover patients in head and body. Facial sides should be opened. For all of our patients, we use the right-sided lateral decubitus or lateral park bench position. Head fixation. Here, I can highlight that we haven't used the Mayfield or any other rigid head fixating clamp. We used a simple horseshoe headrest or holder. So that can be justified that it facilitates and simplifies airway management for anesthesiologists during the intubation extubation procedure, as we have used sleep awake asleep protocol, which is much more easier. And sedation technique in anesthesia was done utilizing the above mentioned protocol. During the induction phase of anesthesia, brain relaxation was provided using the infusion of mannitol and hyperventilation. As an analgesic, we have used fentanyl, not remifentanil, which is standard. Dexmedetomidine injected 5 minutes prior to awakening phase. We haven't used invasive monitoring like arterial lines, monitoring the blood pressure. And instead, so the laryngeal mask is crucial to use because it helps to intubation, extubation stage is very easy with laryngeal mask. And the awake part of the surgery, patients were given dexmedetomidine, and the local anesthesia is very important, providing the scalp block in 6 nerves of the scalp, generous injection of the anesthetics will provide you a comfortable feeling of the patients during the awake stage. So this is the basic points of the injection. Scalp block, as you see, we haven't used any rigid fixation. So propofol infusion rate is then reduced and stopped and LMA device removed and the patient awakens, and resection of the lesion, propofol and remifentanil restarted, in our case the fentanyl, and the LMA reinserted as anesthesia is recommended for closure of the craniotomy. And in many cases, neurosurgeons used the anesthesia after mapping the cerebral cortex, but in our cases we have also used we used cortical and subcortical mapping, and then throughout the resection of the tumor we kept our patients awake. So this is one of the first cases of our awake procedure. It's a 55-year-old female, right-handed. In the history, she was in 2020 April. Firstly, her son came us with the MRI images. She had slight dysphagia. She was not complaining to any other amnestic disorders, and she, like I said before, she was not aware of these kind of procedures, despite we have advised her to provide this kind awake procedure. Because it was the first case, we could not guarantee the successful outcome. Of course, we have tried to explain the whole procedure. So she decided not to operate on the time of the referral. admission, and she decided to take temozolomide. She took it for like 6-7 months, and then, as you see in the MRI, this is after follow-up. 1 year, and the tumor she had expanded in the left frontotemporal region, obviously causing intratumorous hemorrhage, and she was already with dysphasia, but she could communicate that time. So nevertheless, we decided to do an awake procedure. So operation was done successfully, but because of the huge tumor, it caused brain edema during the operation. We encountered the cerebral sylvian veins congestion, so it caused postoperative severe edema, and the edema led consequences with the brain shift. And the first day she has no deterioration of the speech, but the second day the signs of severe cerebral edema and somnolence was detected, so she was shifted to emergency department, and we had to do a cranial decompression, and the histology was anaplastic astrocytoma, and she fortunately recovered successfully. Follow-up MRI investigation after 5 months later, and concomitant using the adjuvant chemotherapy. Her speech abilities was not deteriorated. Still, she could communicate using some words, and this is follow-up after 11 months. She was doing quite well, and no motor deficits, but she kept a little bit dysphasia that time. So the intraoperative neuropsychological tasks we used as a standard: number counting, reverse counting, object naming test, PPTT, and word repeating test checked the transcortical speaking aphasia, and simultaneous movement test to check the multitasking. And this is another case of from our series. So by the time we have developed the better technique of language mapping. So this is a 43-year-old male, slight working memory deficit, no motor and language deficit. So this is left-sided, basically insular glioma, which is expanding to the left opercular regions of the left frontal area. So we decided to do an awake procedure. We was awake successfully, and we tried to map. We used intraoperative inomed monitoring device from Germany. And I'd love to play the whole video. So the patient did well after surgery. The tumor was resected mostly totally, and no additional neurological deficit. And he discharged after 8th day postoperatively. So summarizing the technique, what can be done using less facilities? So we don't really need in rigid head fixation, as many neurosurgical centers does not have rigid head pinning. Adequate scalp block and long-acting anesthetic like bupivacaine is very important, which is eliminating possible pain and discomfort. This is guarantee the patient's comfort. Instead of the rigid head pins, we have used medical tape and provided gentle and soft fixation. No need to invasive arterial lines, no need to remove fentanyl. Timely titration of the ordinary fentanyl can sustain the pre-awake anesthesia and post-awake anesthesia if well calculated by anesthesiologists. No need in neuronavigation, since it's good knowledge of craniometric points and knowledge of intraoperative cortical anatomy is qualified mapping technique gives. So the basic essential task of the mapping is direct electrical stimulation. When you develop a good intraoperative direct electrical stimulation technique, that can be enough as a real-time mapping of the cortical and subcortical areas. No need in intraoperative EEG monitoring, since a neurological evaluation of subtle signs of awakening helps in control of anesthetic agents. So in conclusion, awake craniotomy is a direct cortical subcortical mapping, is pivotal method of localizing eloquent brain area, and high-grade glioma within functional areas of the brain usually penetrate into critical subcortical tracts, which is responsible for complex high cortical functions. Patients with severe preoperative speech disturbance cannot qualify awake surgery. Although low or middle-income countries don't have these high-tech facilities, we should not give up and wait for the better facilities. We can do these kind of surgeries to improve our current state and go further to reach our goals. Intraoperative cortical mapping and language testing with awake surgery can be affordable, and even employing them without neuronavigation and IMRI can lead to better outcome in the terms of preservation of language and movement compared to conventional brain tumor surgical procedures. Thank you so much for listening and your attention.
Thank you very much, Dr. Dilshad, for that comprehensive presentation about awake craniotomy and sharing some of your personal experiences. Without delay, we definitely have an expert today for this thing, Professor Abida Shah. So I would like to request Professor Abida Shah to please comment on Dr. Dilshad's presentation and give your some personal experiences, some tips for the young neurosurgeons.
It was a very good presentation, Dr. Dilshad, and it is nice to see that you are using awake craniotomy for some of these tumors, because it is important in some locations. Of course, I don't use it for all, but for some of these speech area tumors, awake craniotomy helps. Basically, when you're doing an awake craniotomy, you have to little bit be quick also in the procedure so that the patient does not tire out, and you have to have your whole team prepared so that they know what to expect and the patient himself should be prepared. In our country, sometimes we have a lot of issues with some patient, actually agreeing to do an awake surgery. So of course, then we modify our surgery accordingly, and we base a lot of our strategy on the anatomical findings. But it was a great presentation. So I wanted to ask you, you do awake surgery only for left-sided tumors or both right and left-sided tumors?
Until now, so far, we are doing it only for the left dominant hemisphere. But studying in the Nagoya University, I have found that some of the patients with right-sided tumors, like right frontal region tumors, they also do awake procedure, but this is a little bit challenging because of the intraoperative testing methods are not well developed for the right hemisphere, which is a little bit complicated. Like spatial cognition and emotional testing is a little bit complicated. Yeah.
And for the motor strip so left side, for even if it is a premotor or motor tumor, you will do awake, or then you do anesthesia and monitoring?
Yeah, we have done this and that methods, both. So we found that doing awake is more like promising, and because in some cases intramotor evoked potentials maybe false positive, false negative responses giving. So the awake procedures, we found it better.
Okay. So very good presentation, Dr. Dilshad. Sachin, I think Ben has a question.
Dr. Ben, please go ahead.
Hello, hello, Dilshad. Nice
Hi, Ben.
Thank you. I'd love to hear from you about your awake craniotomy. So again, my question is about the because there are some cases that we started doing right frontal glioma for the awake craniotomy. So how maybe in your experience in Fujita, or maybe also experience from the expert panel, so how would you map the right 𝑖𝒏𝒄? So if would you try to map right 𝑖𝒏𝒄 in your or any experience with that?
Okay. Telling the truth, I haven't seen how they detect the 𝑖𝒏𝒄 during the I mean the live when I was in the operating room. I haven't seen how they detect 𝑖𝒏𝒄 subcortical tract, how they map it during this procedure, because it's rare. I have, from their archive, from their data, I have seen only 1 or 2 cases, which was done like a year ago, maybe. So it was basically for frontal Aslan tract. They were using the Stroop test, but for 𝑖𝒏𝒄, haven't seen. This is also interesting for me, so I'm just doing some kind of research in the right hemispheric lesions also.
I see. Thank you. Thank you so much.
Thank you.
And I can see Dr. Hari Kiran, you have a question as well.
Yeah. Hello, Professor Dilshad. Yeah, thank you for your excellent talk. Usually where I work, the most common problem which we encountered was the patients when we explained them about awake surgery. Around 50% of the patients refused for surgery, thinking that maybe because if the patient is awake during surgery, he thinks it's I don't know, but most of the patients refuse for the awake surgery. So any tips how you counsel the patient, or how
yeah, thank you for the question. Yes, we have the same problem. Actually, this is what we call the low informedness of the patients and their relatives. So usually I sit with this whole family together. I show the videos, I show the pictures, I even draw how the operating procedure goes on. So I try to reassure that using the method, awake method, we can spare your eloquent areas. If we don't use, we have a greater risk to lose these functions. So they think, they reflect, if they are ready to do this. Basically, the first line is for the patient. So he is mostly responsible for his actions. So if he's sure to be calm and adequate during the procedure, then we go to the awake surgery. If he's not, if he or she is not ready for this kind of surgery, we just don't force them to do it. And this is like natural course of the any other disease. Yeah.
Thank you. Thank you.
Thank you.
Thank you. Thank you very much, Dr. Dilshad. May I request Dr. Alexander Wozniak to make some comments and give us some tips about awake craniotomy. Thank you.
Okay, thank you. Dear Dr. Dilshad, thank you very much for excellent presentation. Actually, many questions I wanted to give just were answered during your presentation, so I had the answer. But I have some comments and maybe some advices for you, because we went the similar way many years ago. Also started with nothing, but we were intended to do something new, something interesting, and my congratulations that you are the same way, that you even you have not enough instruments, enough equipment. You are doing and you do it successfully. Very nice cases, very nice results. So my congratulations again. My first rigid fixation was the custom-made copy made in my country. So my advice, you can advise you to some of your masters in your city. You always can find a normal master to make a copy of Sugita frame. Sugita frame is an excellent tool. It's very simple to make it. It works perfectly, because if you have not a normal rigid fixation, you lose the candidates for awake surgery. So my advice just to have a rigid fixation, not Mayfield, but something like Sugita. It's easy. It's not cost not a lot. There is a very good publication by Professor Dufour. He established very well that any kind of awake anesthesia is much more better than regular stimulation during anesthesia. So right side, left side. In majority of cases where you deal with the eloquent areas, it's better to have awake patients. The function result will be better, and sometimes resection will be more radical also. So we use awake routinely in our practice, and if you use it every week, it's very easy, and it doesn't require no additional time. When you have a trained team, anesthesiologist knows what to do, nurse what to do, your surgeon assistants prepared, and they do. What I do the next, I do not do it to control the more complex mental functions, to control the emotions. It's interesting for me, but I need a specially prepared, specially trained, I think, like psychologist maybe. I do not have still, but I think in my practice it will be the next step. But there is another side of this of control of these functions. So maybe like an example here, I can say about, for example, right subcortical glioma. You can resect it absolutely, totally, absolutely radically. But if you will do the emotional testing, sometimes you could be forced to stop. So for me, I do not know would I stop or not. So I'm not sure about that.
Which is the most complicated part of the right hemisphere.
Yes, this is the next step for me and for you. So, but in general, congratulations. I'm happy about you, and I wish you to move on and develop and move on. And thank you. Thank you.
Thank you very much, Professor Alexander Wozniak, for encouraging Dr. Dilshad. He is undoubtedly an exemplary young neurosurgeon for all the young neurosurgeons from Central Asia. So I request Professor 𝒂𝒑𝒂𝒍 to make a comment, and then we'll go for the next topic. Professor 𝒂𝒑𝒂𝒍.
Yes, thank you very much, Professor Dilshad. Salam, Mubarak. Thank you. So, yes, it's a nice presentation, and we are in the same case, and because we haven't enough equipment and neuro navigator, neuro monitoring, and also not enough anesthesiolog for this. We use always awake operation, especially for trauma and also for tumor cases as well. And sometimes we have a lot of trauma cases, mass casualty cases, and we do awake operations, but local anesthesia, and that you mentioned, it's fit for low and middle income countries like Afghanistan. And thank you very much. It was good, and maybe we shall come to Uzbekistan and share our experience. Yes. Thank you very much. This Dr. Bakhtiar Burhani, Professor Bakhtiar Burhani, but as he also doing a lot of cases during the war, internal war in Afghanistan as well. Dr. Burhani, salam. Thank you.
Thank you. Thank you very much, Dr. 𝒂𝒑𝒂𝒍. Now let's move on with the next presentation. I'd request Dr. Ben to kindly introduce our next young neurosurgeon speaker.
Sure, and thank you, Sajjan, and thank you all. So our YNS speaker coming next will be Dr. 𝑁𝒉𝒆, who is working in the Department of Neurosurgery, the School of Medicine in Jining Hospital, Nanjing University in China. So today his topic will be surgical treatment of craniocervical junction dual arterial venous fistula. So may I request Dr. 𝒉𝒆 to share his screen?
Yeah, can you hear me?
Yes, I can hear you.
Me? Yeah, I'll share the. Yeah, I'll share the PPT. Can you see?
Waiting. Yes, we can see your PowerPoint. So can you screen in?
Yeah. Okay.
Mode? Yes, nice.
Can you see the PowerPoint?
Yes, it's working well.
Okay. Hello, everyone. Sorry for late for entering the meeting because some problem with my logging in the Zoom. So at last it figured out. So today I'll show you two cases about the surgical treatment of dural anterovenous fistula at craniocervical junction. So mobility dural anterovenous fistula is defined by a pathological connection of an extradural artery through the dural to an intracranial spinal vein. 𝑑𝒓𝒑 accounts for around 10% to 50% of all intracranial arteriovenous fistula. Yeah, cranial cervical 𝑑𝒓𝒑 represents a rare particular subset that constitutes 1% to 2% of intracranial or spinal 𝑑𝒓𝒑s. Its inclusion criteria is patients with 𝑑𝒓𝒑s located at the cranial cervical junction from foramen magnum cranially extending to up cervical spinal cord C1 to 2 levels caudally. So its clinical presentation, about half of the patients with 𝑑𝒓𝒑 at the cranial cervical junction present with SH, which also includes spastic limb paralysis and sphincter dysfunction. 𝑑𝒓𝒑 at the cranial cervical junction, like other parts of the spinal cord, may have a long clinical course followed by acute progression with signs and symptoms. but subarachnoid hemorrhage is the most acute onset. Auxiliary examination mainly rely on CTA, MRI, and cerebrospinal angiography. Note that the most common cause of SH is intracranial aneurysm, but DFF in the cranial cervical junction is a rare cause that sometimes needs to be considered. So we diagnose DFF when the results of intracranial cerebrovascular angiography in SH patients are negative. It is necessary to perform bilateral vertebral angiography and pay attention to the actual cranial segment of vertebral artery to prevent misdiagnosis. If bilateral vertebral angiography doesn't find abnormalities, attention should also be given to the cranial cervical junction DFF, which is supplied by other arteries in the neck. The drainage vein of DFF can be divided into two types. Type 1 drainage vein upward into the intracranial and eventually into the venous sinus. The blood flow in the drainage vein is large, so it is easy to lead to blood vessel dilation and the formation of venous spores and cause bleeding. Type 2 veins do not enter the venous sinus and the blood flow is not high, so it is not easy to bleed. So if 𝑚ethylprednisolone is treated as myelitis or demyelinate disease, the symptoms will be significantly aggravated, which is conducive to differential diagnosis. So early treatment after initial hemorrhage will be required. The surgical treatment is more effective and safer than endovascular treatment. In the current area, the treatment of choice for DFF is endovascular embolization by occluding the fistula's point. However, specific DFF, including DFF at cranial cervical ejection locations, remain more favorable for open microsurgical treatment because of the arterial feeders from eloquent arteries or small direct feeders from a parent artery like vertebral artery. So endovascular treatment of DFF of the CCJ has a high risk of embolic complication. The suboccipital posterior median approach with direct view of fistula and drainage vein amputation is currently an effective method for the treatment of this disease. Intraoperative andocyanide green fluorescence contrast or combined operating room has obvious advantages. Post-operative anticoagulant therapy or antiplatelet aggregation therapy is controversial. So in our department, we don't use either of the methods. So there are two cases here. One case, male, 80 years old, chief complaint, sudden disturbance of consciousness for 1 day, physical examination, coma, no response to tickling, no eyes open, double pupil diameter is 2 millimeters, sluggish light reflex, and ventricular assisted breathing, bilateral Babinski sign positive. Contrast grade is the 4th grade. Here we can see the preoperative CT scan of the head, and we can see subarachnoid hemorrhage, especially in the prepontine system. There is also hydrocephalus enlarged, we can see the enlarged ventricles. So considering the age of the patient, deep coma, and intubation ventilator assisted breathing, external ventricular drainage was performed first to stabilize the vital signs and communicate with family members. Here we can see the CT scan after external ventricular drainage. The drainage tube is in good position. So after external ventricular drainage, the patient's condition tended to be stable, with slight flexion of the limbs tingling, but spontaneous respiration was still weak. Ventilator assisted breathing, and after communicating with his family, he was further admitted to the hospital, and cerebrovascular angiography was performed first. Here we can see the dilated Wiener's balls. Here we can see 𝑑𝒓𝒐 of 𝑐𝒍. The fistula is at the entrance of the left VA into the skull. Here we use 3D DSA dual volume reconstruction technology. It showed the relationship. Between the fistula and the bone. We can see the foramen magnum, the fistula here, and the vertebral artery. Here, this is the arcus posterior atlantis. Dural arteriovenous fistula was considered to be diagnosed in cranial cervical junction area. After repeated communication with family members, dural arteriovenous fistula resection was performed. Here we can see sub-occipital posterior medium approach is enough. So we open the posterior arch of the atlas, especially the left side, and bite outward a little. Open part of the C2 sinus process and the lamina, exposing the fistula. On the lateral side of the accessories, accessories is the marker. We can see the vertebral artery and the dilated Wiener's balls. Now here is the accessories. The removal of the dentate ligament facilitates the slight displacement of the cervical pump. Yeah, here we can see the accessories. At last, we remove the fistula. Here we can see the vertebral artery. So the patient underwent tracheotomy immediately after the operation, recovered the spontaneous breathing, and removed the ventilator, and his consciousness gradually improved, opened his eyes with stinging pain to open his eyes when he was called out, occasionally opened his eyes by himself, and his limbs moved autonomously. Here we show the PET-CT immediately after surgery. So the external drainage of the ventricle was removed and the drainage of the lumbar system was performed. PET-CT was reviewed 2 weeks after surgery. This is 2 weeks after surgery. The DSA was reviewed 2 weeks after surgery. We can see the fistula is disappeared. So case 2, female, 57 years old, chief complement headache with vomiting for 6 days. Physical examination, right frontal ventricle external drainage, double pupil diameter 3 millimeters, sensitive to light reflection, neck stiffness, lack of coordination in physical examination, no sound, limbs buckling to pain stimulation. Here we show the CT scan in the outer hospital showed subarachnoid hemorrhage and hydrocephalus. External ventricular drainage was performed. Here we can see the DSA, the fistula. Also, we use the 3D DSA dural volume reconstruction technology to show the relationship between the fistula and the bone. Yes, the suboccipital posterior median approach also is enough. Resection of dural arteriovenous fistula at cranial cervical junction and decompression of posterior cranial fossa were performed. The external ventricular drainage tube was pulled out and lumbar cysternal drainage was performed. Here we can see the 𝑥-𝑐𝒍𝑉𝑖𝑟𝑠. It's a marker of the vertebral artery and the fistula. Here we can see the fistula and the removal of it. So this is the vertebral artery. CT scan was reviewed 1 week after surgery. The DSA was reviewed 2 weeks after surgery. The fistula disappeared. So thank you very much.
Thank you, Dr. Mao. And dural fistulas are mainly treated endovascular, but some form very good surgical indications. And it is good to recognize them and treat them surgically, as you have shown in these 2 cases. Even some fistulas near the transverse sigmoid junction, sometimes, embolization may not be possible. So some of them do become surgical candidates. So thank you for your good presentation. So do we have any questions?
Thank you. Thank you very much, Dr. Liu Mao. I think Professor Bingzhu is also there. May I request some comments from Professor Bingzhu about the dural fistula at CV junction? Professor Bingzhu?
Yes, Dr. Sechin and Professor Maule presented a very good case. And Abida, you mentioned you normally use interventional treatment for this kind of lesion.
Yeah, we're using. What do you use?
I always do the open surgery.
Okay.
Because this is a very dangerous, if you use a trans-arterial approach, use onyx, it's easy to reflux to the vertebral artery.
No, for craniocervical, no. I'm talking about in general. For craniocervical
okay.
open surgery, yeah.
Yes.
Yes.
Yes. For this special location, we normally use
Open surgery.
transarterial approach, the open surgery. And I have a lot of this kind of case, but which I will want to point out is sometimes when you remove the lesion under the microscope, if it's in the hybrid operating room, you'd better do the angiogram immediately, because sometimes there's some multiple fistula. It would be easy to miss some left, still have some small fistula. The maximum amount I have encountered is three fistula in one patient. So we totally coagulate it, but sometimes it's we missed when we begin to treat this kind of lesions. We happened sometimes we missed the left the small fistula, but it can be regrows very fastly because of the pressure difference is quite high.
Thank you very much. So what about the ICG during the surgery? So it is some help?
ICG, because if you use the ICG sometimes, because this kind of fistula normally it's quite deep under the surgical field. Yes, so still have some yes, still it's easy to miss.
Thank you.
Thank you very much.
Okay, thank you, Professor Mao.
Thank you. So we better do this operation in the combined operating room.
Yes.
Yeah, okay.
Everybody wish to have such a nice operation theater.
Yes.
So, Bosniak, any comments?
Yes, thank you, Dr. Mao. My congratulations for great presentation, great cases, great videos. I'm not so much experienced in this pathology. My question is, do you use intraoperative neuromonitoring during this surgery?
Yeah, intramonitory we use it.
Because it's worse to use, of course.
Yeah,
yes.
we should use. Yeah.
Yeah. Yes. Okay. Okay. Thank you very much, and my congratulations.
Thank you.
Thank you. Thank you.
Like Mao, so do you sometimes the traumatic cause? Do you have some experience? Cause?
Some experience. Cause for what?
Trauma. Yes.
Yeah. When I was a young neurosurgeon, I do some trauma.
I mean, a dual pistol. I'm talking about pistol.
Sorry?
History. Do you mean the history of trauma?
No, no. The fistula, dual AVF itself is caused by the trauma. Do you have such experience?
Yes.
Caused by the trauma.
Yeah.
You in the forehead fistula. From here, maybe sometimes it can cause fistula.
Okay.
But the CCG here, I haven't seen.
Should also?
But I think maybe some not very obvious trauma, but maybe some movement, it caused some fistula around here. Yeah.
Thanks so much.
Normally, this is not a inherent disease, you know.
Thank you very much. Sachin?
Yes. So, Dr. Hari, you were trying to make some comment?
Yes. Normally, after the resection of fistula, when do you regularly do the angiogram? Is it the next day, first post-operative day?
Intraoperative.
But we don't have. What is the?
So you mean as soon as possible?
Yes.
Yes. Dr. Mao?
Yeah.
Well, the best timing, if
what is the best time to do the post-operative angiogram?
You mean the first time?
Yes.
Yes.
You mean the first time to sorry, to what?
Yeah.
After the surgery, best
Yeah.
time to do the when do you do the post-operative angiogram?
Oh, you mean after operation? What's the best time to do the angiography?
Yes.
Angiography.
Yes.
Yeah,
Yes.
we usually 2 weeks after operation to do the angiography. Then after operation 3 months, we also do the angiography again, and 6 months, 1 year, that's enough, I think.
Okay. Thank you, Professor Lee.
Yeah, thank you.
So, anybody has any other comments or question?
Actually, I normally don't use DSA after the surgery. Normally, we can use MRI, and if the tortured vein was totally relieved, normally means it's already cured, and normally the MRI follow-up is enough.
Okay.
Good.
Okay.
Yes.
Okay. So, anybody has any other comments, or Dr. Oras?
Dr. Lee, thank you for presentation. I just here answers my questions. So it was good presentation. Thank you for presentation.
So thank you very much. If there are no other further questions, then I would request first Professor Abhidasha, and then after her Professor Yoko Kato to please make some comments about today's webinar. Dr. Abhidasha.
Thank you, Sachin. I think all the 3 topics were quite interesting. For the first speaker, it was quite amazing to see the results for these abnormal, movement disorders, rare movement disorders, and to see such satisfying results with some lesioning that he has shown us. And of course, Dilshad showed good experience of his awake craniotomy cases. And I wish him all the best to doing some more. And Professor Mao also showed 2 interesting cases of craniocervical dural AV fistula. And they are rare. We don't see them that often, but surgery is, of course, the best treatment for them. So back to you, Sachin. Professor Kato.
Okay, thank you very much. So already Abhidasha and everybody said the 3 talks were very nice. So especially the movement disorder is very rare. So we learned a lot from Horisawa sensei. And also the awake surgery is extreme, I think, minimally invasive treatment, because we can talk, we can see the patient during the surgery. Not for the developing country, but I think it's really minimally invasive, the treatment, I think. And also the final lecture, Dr. Mao, it was really rare, but we learned a lot from your technique and also the concept how to treat. And also thank you very much for Dr. 𝑠huibin. even a very hectic schedule, after the hectic schedule, we are so happy to hear you joined. And also the Bosniak, you must be very busy.
Thank you.
So we will,
very
yes,
much.
we will invite him to Tokyo meeting in next the February. Yes.
I am sending the document this evening. I will send.
Yeah.
I will
Okay.
send
So we are very much looking for you coming to Japan.
Thank you.
Thank you so
My pleasure.
Yes. Sachin, thank you so much, and Ben, and everybody. Good
Thank you.
night. Thank you. Sachin?
So before we close, I have 3 announcements to make. The first announcement is our next webinar. So as I said, we conduct the webinar on every second and fourth Sunday. So next webinar will be on the second Sunday of July, next month. That is on 9th of July, same time, 7 o'clock, Japan Standard Time. That is first thing. Second thing, next month, 29 July to 1st August, we have our second World Young Neurosurgeon Congress, a conference dedicated exclusively for the young neurosurgeon. So we have 8 hands-on workshop, and followed by there is a young neurosurgeon award session. So now it's only 1 month left. If all you want to send the abstract as a special case, we will accept your abstract. Please ask your young neurosurgeon, your friends, your colleagues, your juniors to come and take the benefit of this special conference. It will be in Indonesia. That is second thing. And third thing, I would request Dr. Dilshad to make the announcement of his conference in Tashkent. Dr. Dilshad.
Yeah, thank you, Sachin, for introducing. As previously announced, we have been preparing a ACNS conjoint with International Society of Minimal Invasive Surgery Congress, so-called Silk Road Congress in Tashkent. It is going to be 15th, 16th, 17th of September this year. So we are continuing with abstract admission. So it is open, and Dr. Ben, Sachin, and Boonseng Liv, and I, we are in the secretaries of this Congress. So anytime you can just address us, reach us, and we are open to connection and the collaboration in this coming Congress in Tashkent. So you are welcome.
So I think Dr. Sachin, so maybe would it be possible to invite the young doctor from Ukraine or Afghanistan?
Okay, we'll invite
to either or Tashkent or your Congress, Surabaya in Indonesia. So is it possible the Bosniak?
Yes, I think so.
Can they come? Can they come? Your colleagues?
I'm not sure that I will be able, because I have a meeting in the beginning of September, and then the end of September ENS meeting. So I'm not sure that maybe online. I will attend it online, but I will talk with my colleagues. I know that some of my colleagues are coming. They will participate in person. Maybe I will recommend to somebody else. Okay.
Yes. Such maybe it will take a longer time to take getting the visa. So if you wish, maybe yes. If you wish, maybe you can start right now.
Yes. I will send you all the paperwork today evening.
Okay, thanks.
I'll send you the mail of the scientific program of both the conferences. Please share it with your young neurosurgeons, and those who are interested can contact me. So I'll facilitate their visa and the invitation letter.
Okay, great. Thank you.
Thank you. So wonderful webinar today. Thank you very much. Arigatou gozaimashita.
No more.
Thank you. Bye.
Bye.
Thank you. Bye-bye.
Arigato.